Hi, everyone. My name is Gabriel Altit. I'm a neonatologist at the Montreal Children's Hospital, and I run the neocardio lab with the rest of the team of the neocardio lab. And today I'll be presenting actually a case for our case presentations. And instead of typing up the case, I decided to go over some of the image clips we acquired and go over a bit some of the physiology to discuss an interesting finding. So, I wanted to also review some of the concepts of evaluation of RV systolic pressures and systolic pulmonary arterial pressure assessments in the context of when there are shunts and when there are valvular obstruction or insufficiencies. So, really briefly, this is the typical case of a baby who was born in a preterm range with appropriate growth during gestation and postnatally, and for which we were involved in the screening for pulmonary hypertension at 36 weeks because this patient was still on some degree of respiratory support, so CPAP of 7. With no oxygen support, actually, in room air. And we were asked to rule out pulmonary hypertension by echo. And so, as we do, we always assess the patient prior to the echo. So, blood pressure, we evaluate the story. There was no particular, um, concern regarding the story of this patient, except that this patient was born in the context of a twin-twin transfusion syndrome, which did not meet criteria such as high Quintero staging for laser photocoagulation during pregnancy. And this patient also eventually got born preterm and had an uneventful course. So at the time of the blood pressure, and this patient was a recipient twin. So blood pressure at the time of the echo was 84 on 43. And the patient was saturating 100% pre and post ductal, had a benign physical exam, no hepatomegaly, and well perfused clinically with relatively minimal work of breathing on the respiratory support. So we'll go over some of the views. The first one is a parasternal long axis view, and you can see that already the RV, which is a portion of the RV outflow tract, knowing that the RV is tripartite and so has an inflow portion, a body portion, and an outflow tract portion. So in parasternal long axis, this is a portion of the RV outflow tract, and we see that as we angulate the probe posteriorly, we see the inflow portion, which is the tricuspid valve and the right atrium. So far, no big concern, except that maybe the RVOT zone looks a bit generous and maybe slightly hypertrophied in terms of the free wall, but that's a very subjective finding. Upon fanning the probe more anteriorly, we start seeing the RV outflow tract more precisely with the pulmonary valve here, and it's quite striking that the RV outflow tract looks narrowed and that the pulmonary valve, which there is a zoom here, looks crowded. We call this doming pulmonary valve, which means that the pulmonary valve is not opening fully and smoothly, but there's actually like almost a dome of the component of the cusps, which is creating potentially some obstruction or pulmonary valvular stenosis. We can see here some of the cusps of the pulmonary valve in this particular cut in parasternal long axis, and we can see that it doesn't open nicely and smoothly fully. Here we are putting some color with simultaneous 2D view or beam mode view. You can see that the Nyquist is at 139 centimeters per second, which really should filter out some of the lower velocities of blood flow. And so this is relatively a high velocity of blood flow. And we can see that despite this, there is aliasing through the pulmonary valve. Blood flow does start before the pulmonary valve and goes through the pulmonary valve, but there's definitely some degree of aliasing and turbulence secondary to the incomplete opening of the pulmonary valve. We can also see a red flow, which is likely the ductus arteriosus. It is actually the ductus arteriosus. that is still patent in this particular patient, which is important because in the early stage of life, it can be very hard to fully assess the degree of severity of pulmonary valvular stenosis when the pulmonary vascular resistances are still relatively high, and especially when there's a duct wide open, which may compete with the flow coming out of the RVL flow tract. So we may underestimate the degree of the pulmonary valvular stenosis, but this patient is already about 10 weeks old. So PVR are expected to have dropped. So here we've put a continuous wave Doppler. You see it here, CW, with the line of interrogation passing as much as possible in line with the pulmonary valve and right ventricular outflow tract. And we can see that the gradient, depending on where we take, because there is some component of aliasing, and typically we don't want to take those little hair, or like example here, these little hair, but really we want to take as much as possible the kind of chin of the spectral envelope. And so we get about, depending on the envelope, here I've put the highest we got, which is 90 millimeters of mercury, but it was oscillating between mid 70s and 90 millimeters of mercury of gradient. So it tells me there's a gradient between the RV and the pulmonary artery of at least 90 millimeters of mercury based on the modified Bernoulli equation, because the velocity of flow going through the valve is 4.75 milliliters per second. And so if you're putting this in the modified Bernoulli equation, it's 4 times v to the square, and it gives you an estimate gradient between the two structures, which is the RV and the MPA of 90 millimeters of mercury. So we go on. Here we went a bit posteriorly, and we're capturing a bit of RV insufficiency, which is really trivial here, but we can appreciate there's a bit of RV hypertrophy in the background, in the body, in the inflow portion and part of the body of the RV. Here we get into the parasternal short axis view, which is slightly modified to also visualize the ductus course. So we have the descending aorta here, we have the ductus arteriosus, we have the left pulmonary artery and the main pulmonary artery. We have the pulmonary valve that we can appreciate is also doming from this view. And we have a duct that is, small to moderate, I would say. We can see it here where there's an area of constriction and collar flow that we see, but we also see it in 2D in this dynamic view. So really, this is inferior to the diameter of the LPA. So we would probably call this ductus relatively small in this context. And it is left to right in the sense that it's red and it's going towards the probe, again, at very high velocity in terms of Nyquist. And so when you obtain a gradient through the ductus arteriosus, you can see that its pattern is relatively restrictive in the sense that we have relatively high systolic and high diastolic velocities. And at the peak of systole, so you see the cuirass here, and you can see that the gradient builds up during systole, we get a peak of about 60 to 61 millimeters of mercury in peak systole, which tells me that the systolic pulmonary arterial pressure is about 61 points or 60 points below the systolic aortic pressure. Now, we know that the PDA is a tubular structure, so the Bernoulli equation may be either over underestimating, depending, but Bernoulli equation shouldn't be necessarily applied to a tubular structure. It really should be applied to a point of constriction. And so this is not a point of constriction, it's really like a tube of constriction in a way, but because it acts a bit in a cone, velocity will dampen along its path. So obviously it may underestimate the true gradient, but we know it's at least in the range of 60 millimeters of mercury. So this is another view where we see that there's flow coming from the RVOT and feeding into the main pulmonary artery and with the duct in the background. And then we shift to the parasternal short axis view, where on the sweep, we can see that there's, globally good contractility from the base to the apex of the LV. So it's important to look at, every area of your LV to make sure there's not segmental issues in function. But we can see also or appreciate that in systole and even potentially a bit in portion of diastole, there's a bit of flattening, although it's really more pronounced in systole that you get a bit of this septal flattening at the mid-papillary level. And this tells me that the RV pressure at least 2/3 to isosystemic, so similar to the systemic compartment. So now we get into four-chamber view. We can appreciate the RV and LV sizes. So the RV doesn't look particularly dilated in this particular view, which shows me the free wall and the septal wall. We can see here the TAPSE where we get about, about 1 centimeter, which is completely normal for a near-term corrected age patient. So a vigorous RV systolic function. So now this view is a TED view, where it's a view where we can appreciate the RV outflow tract as well as the inflow portion of the RV. Some people will call it an apical three-chamber view. Here we can appreciate a bit of RV hypertrophy in the background, maybe slightly more than what we would anticipate at this particular postnatal age. Very typical to see in the first early days of life in some of these patients after birth because of the transitional physiology. But at 36 weeks, 10 weeks later, when the PVR have dropped and typically the RV has remodeled, if the PVR are low and the patient doesn't have pulmonary hypertension or RV hypertension, the RV should look much less muscular and bulky. So here we see again that the valve has some degree of tricuspid insufficiency, which can be, would be mild to moderate. Typically, we call severe when you get signs of RA dilatation, which to me doesn't look super dilated, but it's very subjective, and I haven't measured the RA planimetry. And then we also call, the TR jet in the neonatal period. There's a bit of controversy about how to quantify severity of TR jet, but if you reach the roof of the RA, typically it's in the moderate to severe range. So I would say, around the moderate range, because I suspect that if I would extend my collar box to the full atrium, there might be extension there. And we can see here, appreciate a bit more that there's a bit of crowding inside the RV cavity or a bit more hypertrophy, which may be secondary to the high RV afterload, secondary to the pulmonary valve blockage or stenosis. And this is an extension of the TED view or apical three-chamber view of the RV, where you see the aorta in the background, the inflow portion, and eventually the outflow portion. And you can see that there's a lot of aliasing here. This is a particular good view when you have a duct or when you have turbulence in your main pulmonary artery that may obscure your Dopplers of the RV outflow tract. It's a good view where you're nicely aligned into the path towards the main pulmonary artery if you want to obtain a pulse wave Doppler just before the valve or at the level of the valve in order to estimate RV output or to estimate at least the pulmonary acceleration time to RV ejection time. Although in this particular case, because of the pulmonary valve stenosis, I don't think that these measurements are reliable and providing us really insight about what's happening downstream in the pulmonary circulation. So we wouldn't necessarily be able to apply these concepts to this particular case. So we obtain a CW Doppler along the tricuspid valve to estimate the TR jet velocity. So this is tricuspid valve, and this blue jet is tricuspid regurgitant jet. And here you can see that, I think we are well aligned as much as possible. Although the curve is not exactly fully complete, we get at least a peak of around 85 to 90 millimeters of mercury, trying to avoid taking too much of the hair. So, I think it's closer to 85, but could go up to the range of 90 millimeters of mercury of right ventricular to right atrial gradient based on the TR. And we'll go over those numbers after. And then finally, a quick overview of the subcostal view. And obviously, I've selected some of the clips that we acquire in our TNE. There's much more than that, but for the purpose of this particular case, this is what I wanted to provide in terms of a snapshot. So this is a view of the subcostal. You see the liver, and this is what we call the short axis in subcostal because you get to see a bit of the short axis of the left ventricle as we sweep. So I'll show it. It's here. So now if we start from the beginning, we see the SVC and IVC in the bicaval view, and eventually we see the RV outflow tract, and then the signs of acceleration. So bicaval view as we sweep the RV outflow tract acceleration, and we even see a bit of the PDA towards the end. We'll see it here. It's this red flow here. Okay, this is the actual long axis view, which is a good view to get a sense of interatrial shunt. So we see the RA, the LA, and we can see the interatrial septum. And you can see here that there is an interatrial shunt, which is actually bidirectional, although it looks mostly left to right in this particular view. And it's a generous shunt at 0.6 centimeter so an atrial septal defect secundum type. We can also appreciate the ASD in this view here. So we'll just give a chance to recycle again here. And so I can tell you that there was a brief moment of right to left, but it was mostly left to right, which explains why this patient is saturating 100% because there's really not much RBC from the right atrium that are entering the systemic circulation. So basically you have mostly a left to right shunt at the interatrial level and a left to right shunt at the PDA level. And so the systemic blood is non-contaminated by any of the deoxygenated blood coming from the right atrium or eventually the right ventricle into the systemic circulation in this particular patient. So now I'm going to share just to go over some of the concepts. And so here, this is the concept of RV outflow tract obstruction. So, if we take babies with severe pulmonary valvular stenosis or pulmonary atresia, and they don't have lung disease, let's say, the pulmonary veins, because you don't have VQ mismatch in your lungs, all the blood flow going to the lungs will typically be well oxygenated, comes back through the pulmonary veins at 100% of saturation, and eventually mixes into the left atrium with blue blood coming from the right atrium. And so that's where you start satting at 85, goes to your left ventricle, goes to your pulmonary, to your aorta, and eventually, because there is no flow going through your RV to the main pulmonary artery, you get a left to right shunt that provides blood flow to your lungs. So this is a lesion that is typically ductal dependent when it's completely atretic, or when you get such a severe pulmonary valve stenosis that you get barely any blood flow into your main pulmonary artery. And so the PDA will feed your lungs and provide blood flow. And so typically these patients will be satting and will be a bit cyanotic because of this. And so you can see that blood coming back from the SVC, IVC, once it went through the body and oxygen consumption happened, at 65% to 70%, eventually you get some shunting into the LA. Why? Because the LA is probably a bit underfilled due to less pulmonary blood flow relative to the systemic flow, but also because you get such obstruction that the RV has a dead end. So there's very high end diastolic pressures. And so RA pressure is just much higher than the LE pressure because of that, since the RA and the RV will equalize pressure in diastole when the tricuspid valve is open. And so a lot of flow will pop off into the left-sided compartment through the interatrial shunt. And these babies are typically blue. Now, when you have a situation where the pulmonary valve is stenotic, you may get sufficient flow through your right ventricle. So first of all, this patient, same thing, get blood flow coming back from the body, and then this flow goes to the RV, but the RV is able to eject and is vigorous. And so despite the obstruction, is able to provide some output into the main pulmonary artery. On top of it, you get some flow coming through the PDA. So probably this patient has either a QPQS that is around 1:1 because of the portion coming from the RV and portion coming from the PDA, or even a bit higher than 1. since the ASD and the PDA are going left to right, it might be a QPQS that is actually a bit higher. So a pulmonary blood flow relative to systemic flow that is higher than 1 to 1. So probably maybe a 1.5 or 2 to 1, despite the fact that there's an obstruction. And so blood flow comes back from the lungs, and this particular patient, he was satting 100%, so there's unlikely to be significant VQ mismatch, especially since this baby is being supported with CPAP. If we would remove the CPAP, there might be alveolar collapse, and the baby might start desaturating because of right to left shunting inside the lungs. But this particular baby being well supported, we get 100% saturation coming back from the lungs, feeding into the left atrium. And as you saw, the majority of the shunt was actually from left to right. So I wrote 65, but probably the saturation here is higher than 65 once it mixes into the right atrium with the systemic venous return. It's probably around 75 to 80 even because of this effect of this ASD. And so because it is bidirectional, there may be little traces of blue blood entering the systemic circulation, but most of the time this patient was satting 100%. So we get 100%, 100%, 100%, eventually 100%, and you get PDA flow that is left or right, also increasing the saturation of oxygen recirculating through the lungs. And so in this particular baby, despite the fact that there's pulmonary valve stenosis, the fact that there's a duct and an ASD, the fact that there's a duct, first of all, contributes to pulmonary blood flow. And at this point, the pulmonary valve stenosis, although relatively significant, the RV is still able to provide output into the MPA through the obstruction. So the other thing I wanted to go for is that, obviously this is an important finding to potentially eventually address through balloon valvuloplasty and, balloon dilatation of the valve to, prevent eventually RV failure and RV remodeling. But if we would go through the dynamic of the echo to try to understand, well, does this patient have signs of high pulmonary arterial pressure despite this RVO flow tract obstruction? Well, first of all, we know the systolic BP is 80 millimeters of mercury by cuff, which represents the systolic aortic pressure. And so we know that the peak gradient we get is about 60. So we already know that it predicts about a systolic pulmonary arterial pressure of around 20, because 80 minus 60 of gradient gives you about 20 of systolic pulmonary arterial pressure. Now, if we take the other numbers, so we got a TR jet of 75 to 90, which gives us an RV systolic pressure of around 80 to 95 millimeters of mercury. Why? Because this is a gradient, and you assume that your RV pressure is around 5 millimeters of mercury, although it may be slightly higher because of the interatrial effect, the shunt. Well, not just because there's RV hypertrophy, the RV pressure may be a bit higher, and we saw that there was a bit of bidirectionality, so probably it tells us that the RE and LE pressure are relatively equivalent. So I suspect that the RE pressure is more 5 to 7 millimeters of mercury, knowing that usually RE pressure is always slightly lower than the LE pressure. But in that case, we're going to use a 5 millimeters of mercury because I don't think it makes a huge difference in this particular context. So if you would take your TR jet, which is around 90, and you 5 millimeters of mercury, it predicts an RV systolic pressure of around 95 millimeters of mercury. We know the pulmonary valve gradient is between also 75 to 90. And so it does tell us that, if you remove 95 and you remove it from the range of 75 to 90, so we'll take something like 80, which is a bit of an in-between, it predicts a systolic pulmonary arterial pressure in the range of 15 millimeters of mercury. So we're getting into ranges of 15 to 20, which is considered normal at around 2 to 3 months of age. We locally use a cutoff of 40 millimeters of mercury, 35 to 40 millimeters of mercury, as something that raises concern in terms of high systolic pulmonary arterial pressure. So this is just to give you a sense of the question was, is there pulmonary hypertension? I don't think there is pulmonary hypertension. I don't think there's high pulmonary vascular resistances. just based from the directionality of the duct, the gradients. Definitely, based on these numbers, there's no signs of high pulmonary vascular resistance. Now, there is this other finding that needs to be addressed. Um, um, and it's important that when we do these assessments, we make sure we don't miss them. So what I want to finish is just rapidly go over in the TNE section. There's really a section already dedicated to twin-twin transfusion syndrome. And within it, there's a great presentation by Dr. Annie Lapointe from Saint-Justine that she did for the Neonatal Hemodynamic Research Center, and some great slides that were put together by Dr. Ida Whiteman and Mrs. Christina Huber in the context of one of our NICU cardiology rounds. So I do invite you to go over these slides and this presentation if you're more interested about the really interesting physiology of twin-twin transfusion syndrome, where they do share a unique vasculature, and there's a component of transmission of hormonal messaging. So, for example, the regulation of the renin-angiotensin system in one fetus will be eventually transmitted to the other fetus, and so may have some paradoxical effect on top of the various loading conditions throughout the pregnancy and during embryology. So, very interesting to go for. And there are some really wonderful articles related to the TTTS effect on the heart. One of them being by Nikki Manning and Nick Archer, which is 2016, but still very, very accurate. And within it, they provide really a great overview and review of some of the changes that we may see in some of these patients. And most importantly, they provide this great table where they explain a bit why the recipient twin is at high risk of developing right ventricular outflow tract obstruction, and why the donor twin may be at risk of developing LVOT slash aortic arch issues, so the systemic outflow tract, just based on the physiology and the loading conditions during embryology. And so these patients in general are at risk of developing, some signs of valvular RVOT obstruction because of the myocardial hypertrophy, because of, various loading conditions that they get. And so, very interesting to go over this article, which is not something I will, but I did put on top of this page a nice explanation about some of the effect that we see in terms of RVOT anomalies and how they should be screened. But you can see that there's quite a significant amount of patients that may develop some of these findings. So this was the case for this month. And so I hope this little videos was valuable to go over some of the views and the rationale and what information they provide you. And I wish you all a great day.